Ladies and gentlemen, welcome to this, our September board of the Wye Valley Trust. As you can see, we're still having all of our board meetings virtually in this digital format because of the COVID pandemic and the desire to make sure that the hospital and our colleagues are as safe as possible. So we do hope you're finding the YouTube format helpful to keep in touch. And I would encourage, if any of you have any questions which you'd like asked at the end of the board, please do provide them either to myself or Erica Herman, and it would be our pleasure to address those in the public forum. So we have apologies today from David Mowbray. Do we have any new declarations of interest from colleagues? Please come off mute if you do. Okay, so before we get on to the minutes, just so members of the public are aware, we had a comprehensive board workshop this morning. We talked about the fantastic innovations that have gone on with the pharmacy department and the volunteers. And I'd like to reach out and thank all of our volunteers generally, but those who've been working with the so-called Pharmy Army are fantastic, whether it's the runners in the hospital, those on bikes or providing their cars. We are incredibly grateful and appreciative of the work of our volunteers, and it's had a real impact on us being able to provide the level of service we have during the COVID pandemic. We then had a really interesting session on leadership across the group, as well as our inpatient survey. So we've had a number of hours already as a board this morning. So the minutes of the meeting held on the 6th of August, was everyone happy with the accuracy of those minutes? Please come off mute if you'd like any changes.
Russell, just a minor correction.
Thank you, Richard.
In the opening paragraph, the first sentence, it refers to the real challenges faced by care homes, domiciliary care and rest homes. Could we delete rest homes? Because actually there's no such thing. Okay. And it might be easier. It might be easier to say the real challenges faced by care providers.
Okay, let's make that adjustment because I think that's more accurate. And as you know, Richard, and the funding settlement for care providers from the end of September through local authorities is still very uncertain. So our sympathy is with them, and our appreciation of the phenomenal efforts they've gone through during COVID, and our local authorities and the funding challenges they have is a very real challenge. So out with that change, everyone happy for me to sign the minutes? Thank you, so I duly will. Therefore, we go to page 14 of our pack for the matters arising. The first was a board workshop on leadership styles. We had that this morning. Jeff, thank you for organising that and leading it. The second was around quality, and Lucy to review whether there are any areas of exposed pipe work within the trust. That work's been done and should be completed by the middle of September. Is that correct, Lucy?
That's right, and I would just want to add there was no exposed pipe work in the acute. The challenges were in the community hospitals, and it's within the community hospitals that the work will be completed by the second week in September.
Super, thank you very much, Lucy. And then the next point was for Howard to review the extent of the private patient debt to the trust. That's been done and figures have been provided. Thank you, Howard. And then on the digital programme update, how to confirm whether patients and GPs attend the stakeholder group for the EDS. That's been done, the GP groups are involved. However, we're liaising with a single GP representative who's been invited to the EDS meetings. Patient groups are not currently engaged, but that's a suggestion that's been put forward to that team. Thank you, Howard. In terms of actions in progress, how to review how typical the substantive medical staff additional payments are. That's been conducted within a general review of the foundation group. For members of the public who may not be aware, Wye Valley Trust is part of a foundation group of Wye Valley Trust, South Warwickshire NHS Foundation Trust, and the George Eliot. Glenn and I are chair of all three of those organisations. And what we endeavour to do is to identify and share best practice at pace across all of those three different NHS trusts. On the activity performance, the communication team to ensure that the message gets out to the media to inform patients on the importance of staying on the waiting list. That's an ongoing program of work. So thank you for that. And then in the Chief Executive's report, the Audit Committee to consider the implications of the Independent Medicines and Medical Devices Safety Review by Baroness Cumberledge. That's due for October 2020. That's an extremely important report, which we as a board are taking very seriously and will review in October. Lucy, did you want to make a point?
Yeah, we looked at that outside of the board meeting after the last board, and actually what we've agreed to do is present the findings of the Cumberledge report alongside the new patient safety strategy at Quality Committee at the end of this month.
Great, thank you very much, Lucy. And then John will endeavour to access cancer performance figures to compare our rates with those in the Midlands. John, verbal update, please.
Yeah, the information is not quite available in the same way it was. I have got a national position for June, and we were 33rd best performing out of 137 for 2-week waits, and 70th out of 148 for 62 days. Now, what I can do is that's the whole country. I can provide that link if people would find that helpful. It's available from sort of nationally. That would be helpful.
I think it's just reassuring to our population, John, to see how we're doing compared to other trusts. If you can find a format that allows that to work for you monthly and keep members of the public informed, I think that would be good. I think the key thing to say to members of the public is the NHS is open. Please use it. If you've got any anxieties about a medical condition, please approach your GP or 111 because we are here to help ensure you get the best health outcomes you can. And then finally, on Howard, on the financial plan to be presented to a future Board of Directors meeting, that's scheduled for the October board. So look forward to that, Howard. Thank you. Are there any matters arising that I've missed? Okie dokie. So we can turn to Glenn's Chief Executive report. Glenn, please.
Thank you, Russell. So last time when we met, I talked about the stage 3 or phase 3 letter linked to the recovery planning for the NHS, and at last board it had just landed, so I promised to provide a bit more information. There's a summary of it there in my report. There's also been some further guidance on the way that we will financially incentivise the recovery of elective work. That guidance is not as straightforward as I would have liked, but basically the approach is to incentivise achievement of the milestones, which I'll talk about in a moment, at system level. So as an STP, so for Hereford and Worcester together, there'll be an incentive in us achieving those milestones, or if we don't, there'll be some funding taken away from our entire system. And the key milestones are linked to the elective recovery of activity. So looking at the amount of work we did pre-COVID and what we're able to achieve over this month, over September and October, with the September and October ones being the ones that are financially incentivised and quite ambitious, 80% and then 90% in October, where many, as I've said in the report, felt maybe a 75% ambition would have been something to go for. But we are working as a system. We've got a system review meeting tomorrow with the regional team where we'll talk about our progress against that. But it does add another level of financial risk to scenario planning for this year. This recovery phase covers this period for the rest of this financial year up until what will be called reset, which is from April next year. And obviously it includes the winter period. So one of the most significant things that we need to be delivering over the next couple of months is a flu vaccination campaign. As an NHS, we will be considerably expanding that this year, moving from 2.9 million vaccines to about 5.4 million vaccines, with other cohorts of members of the public including all people aged over 50. And we will be gearing up to offer a vaccine for COVID. The current planning assumptions would be that we would be vaccinating NHS staff prior to Christmas for that if we're successful. That will be a 2-stage vaccine and on similar volumes to the 5.4 million level. So a big campaign, really important message for members of the public, if they're offered a flu vaccination, that they should absolutely take it, and we'll be ensuring that there's a very, very high take-up of all of our staff to keep them safe too. Phase 4 planning I'll talk about in a little while. The day prior to the recovery planning letter coming out, we also had the launch of the NHS People Plan, which included our People Promise, which I've quoted there, and those 4 areas for employers to focus on: looking after our people, belonging in the NHS, new ways of delivering care, and growing for the future. We will spend more time on this as a board over the coming months. There's nothing particularly new in there in terms of what I would say our approach would be for this. What the revised People Plan has done is included some of the learning from COVID, particularly the support mechanisms for staff, an expectation those will continue obviously throughout this winter, but then into the future to be the best employer in the world, and that's what we aim to be locally. And we use things like our staff survey in order to make sure that we can achieve that ambition. And then 2 final things. We were visited by the Prime Minister on a very hot day, where he was able to have a look at the progress that's been made on our Potted Wards replacement project, which is going very well, and that will help us this winter when it opens, Alan, doesn't it, in January? But also on that day, Prime Minister made announcements around additional capital funding for winter, including a 2 billion announcement for us, which will allow us to expand our same-day emergency care. So that was a positive day, and staff were able to talk to the Prime Minister about some of the innovations that have been delivered locally. Particularly the frailty team spent some time talking to him about their work, which was really good, and he repeated some of it back to me, so he certainly listened. And then finally, Starboard. So earlier today was the first meeting of the Midlands Starboard, the Strategic Transformation and Recovery Board, and there's a small number of people involved in it. I'm pleased that I've been able to be involved in it. I'm be working specifically on work stream 4 that's identified there in the pack, which is about how we run NHS Midlands. The aim of all of those working groups is to come up with some ideas that we will implement as quickly as possible. The group that I'm on will be particularly looking at the reset situation, so how we run the Midlands from April of next year, where we will be full-scale integrated care systems, where we'll be focusing more on some of the ambitions of the long-term plan for the NHS. I'm looking forward to that work and to being part of that Midlands Starboard moving forward. And I'll hopefully not clash with board workshops as it did this morning, Chairman. Happy to take questions.
Thank you, Glenn. Questions and perspectives to Glenn. Please come off mute if you have a question. It's a little bit difficult for me to see raised hands on Zoom.
Yeah. Can I make a couple of points, Chair? Yeah, thank you. 2 points, Glenn. The first, in relation to the recovery. I mean, we've got a mountain to climb, haven't we, over the next few months with the reset, with the backlog of unmet need, with flu, with COVID, and with the winter pressures. What I was wondering is how are we going to manage public expectations in relation to what we can realistically deliver, particularly through our relationships with primary care colleagues? So that's my first comment, really. The second question was about this new the new STAR board that has suddenly appeared from nowhere, and whether or when there will be more detail about its purpose, its governance, its membership, and crucially, how might it affect our ability to get on and do the things that we know we've got to do in Herefordshire to transform our health and social care system?
Okay, two really good questions. Thank you, Richard. I'll just take them in order. So the first one on the recovery planning, as I set out earlier, the aim is to try and get those elective services back up and running to reasonable levels before winter hits. And obviously we're expecting this to be a challenging winter for a range of reasons. That will in itself mean that we've got backlogs of waiting lists that were higher than when we entered COVID, and that those are not going to recover dramatically quickly. It's really important for us, though, to give the message to the public that we're open for business, as Chairman did earlier, that we've got safe pathways for all of our services, whether they're urgent care or planned care. And the feedback from patients as they access those pathways is that they feel safe. So those are very encouraging messages. But people will be waiting longer than we'd like them to. So there's a communications exercise across the STP. We'll be writing to every patient on waiting lists to let them know the situation we're in and what our recovery planning is, and to allow them to come back to us and ask questions. And we need to be part of that messaging too. Different specialties will be able to recover differently to this. It will be probably over the winter easier for us, for example, to do some of that day case work, whereas it may be harder to do inpatient work with access to beds. So it's a bit like the problem we've been facing over the last few years, of where we've actually made progress to improve our waiting times. We've slipped back, but we'll need the public to be understanding of that. And we'll need to risk assess individual patients on the waiting list, and if necessary, bring them forward. And as you say, need primary care help with that. I think it's, though, really important that we just don't go back to what we did before, because before there was not equitable access to services. There were some waiting times that were longer than others and shorter than others. So I think that as part of reset, we do need to look at some of the inequalities, and that's certainly one of the national imperatives. So just moving on from that to the Starboard. So the Starboard is a Midlands region idea that Dale Bywater, the regional director, has come up with, and it's in response to a number of challenges that we face, particularly, in my view, the movement to system working without changes to national legislation. And I think it's really important that we respond to those in a way that, in my view, that meets the strategy that we've set out as an organisation. So our strategy is predominantly about things being delivered and run and planned at place level. And place for us is the county of Herefordshire and the services that we provide into Powys. So I think it's really important that we consider decisions and integration in that local system. But obviously, we're part of a bigger NHS. We need to recover and use capacity across the NHS to make sure there's not inequalities in waiting time. So being part of a bigger system, but doing that effectively, is the best way that we can probably recover. Nationally, there's definitely a move to try and use systems more than individual organisations. So I think we have to find a way in the Midlands of working within those national rules, but actually in a way that promotes the delivery of integration and services at place. So that's what we do. It's a time-limited group. There's, say, a small number of provider chief execs involved in the Starboard itself. There's a few more involved in the work streams. I'm fortunate that I'm in both, and I'll do my damnedest to make sure that what comes out of them makes sense and is consistent with the strategy we've been pushing locally for the last couple of years.
Thank you, Glenn. Thank you, Richard. Just keeping the pace going, guys. Any other questions or perspectives? Keeping it going, Grace, please.
If I may, Ross.
So Grace first, please, Frank.
Okay.
Oh, thank you. Thank you. And just following up on what you wrote about the reintroduction of funding panels, I'm just wondering if we have any idea or steer on whether they're going to be shifted so that we don't end up with the same challenges that were there before and the slowing down.
Glenn, thank you, Grace.
Thank you.
Glenn, you're on mute.
Yes, I was talking away to myself there. Yes, one of the things I was not pleased to see in the letter, because one of the freedoms that we've benefited from over the last couple of months or so has been the absence of those panels, and therefore the ability to discharge patients straight out of hospital. What it did include, though, is a national coverage of discharge to assess. So it's saying that for every patient, we should have adequate capacity in those discharge to assess pathways to ensure that they're assessed in the right setting. So that's encouraging, but there is still uncertainty around the funding settlement for the care sector, as Russell said earlier, and there's still certainly tension around NHS funding for some of the continuing healthcare packages. So all we can hope is that we don't end up with delays because of funding rather than the processes of ensuring we offer the right care packages to patients. So I'm nervous about it, Grace, is probably the best way to put it. But system working has certainly improved, over the last few months, and I hope that that legacy will make those panels slightly more effective than they may have otherwise been.
I think the anxiety, Grace, is penny wise, pound foolish, to use the vernacular. And Chris, did you have a question before Frank?
It was about the people plan, and I just wondered at what point we might have a response, Wye Valley response to how we're addressing some of those really important issues within that.
Yeah, I mean, Jeffrey will be working away on this one. We all are also, again, at the system level, there's an expectation we'll have a system people plan. That said, I think a lot of the responsibilities when you read through the people plan are for employers. I mean, we can work as a system to enhance some of those things, but actually it's the way we treat our staff, the way we support our staff, the way we recruit to a value set, the way we retain those staff as a consequence. So I think what I would say in an immediate response to it, there's not particularly new items in here. So things like our overseas nurse recruitment strategies, things like our response that we'd already agreed to our staff survey are still going to continue into the future. There's just one or two nuances that we'll just need to review, but I'm sure we'll spend some time in workshop and board looking at that as we over the next couple of months.
Thank you, Chris. And finally, Frank.
The financial dilemma that you referred to in the first paragraph, Glenn, do we have any feel for what the upside and the downside of that is? It might be a question for Howard to answer offline, but I wonder how big that challenge might be. And my second question, the national conversation at the moment is about working from home. The flavour in your report is still very much encouraging working from home, but the national mood seems to be going away from it. Is that typical in the NHS? We're likely to see that change come through or not? So
I'll take those two in turn then. Firstly, on the money, we were expecting further guidance actually and clarity on the money situation, and that has not arrived yet. We were supposed to get system funding envelopes and clarity on how much money was available for the rest of the year to support COVID. That's not arrived. The calculation around whether Howard's been able to get his calculator very hot on the number of sums we'd need to do to work this one out. I'll let him answer that when I've finished in a moment, but it's quite a confusing picture. I also understand, although it wasn't in the letter, that these payments are likely to be retrospective, potentially year-end payments, which probably mean that we won't be able to do much with the money in year anyway. So, but Howard may want to comment in a moment. And the second question, sorry.
Working from home,
sorry, yeah. So, yeah, I mean, our staff have responded with lots of innovation, and so we are encouraging, I mean, and actually things that I thought couldn't be done have been done using technology. Our managing director joins us from a holiday on the south coast somewhere. So we will be, you know, if people can work safely and effectively, and actually the productivity of home working has been proven to be really positive, we should continue that. And it will also help us to manage COVID in the workplace as well, because obviously the distance between staff working in the workplace has had to be extended, so we've lost capacity. For patients also, it's been more convenient for many patients to have telephone follow-ups, to have digital clinics. But of course, there are many patients who need to be seen face-to-face by the clinician. And so we'll be doing a mixture of those moving forward. But we're embracing new ways of working, particularly in a county like ours. It's a good opportunity from a recruitment retention perspective, but also to make ourselves more accessible to patients.
But from the national perspective, the emphasis is pulling away from that. Is that pressure coming through the NHS or not? Yeah,
and I mean, the national perspective is, in my view, I'll give a personal view, is more about the shops and cafes of London rather than necessarily what's going on in a place like Herefordshire.
Okay, guys, really want to move us forward. That's been a very comprehensive discussion with Glenn, but we do need to pick up the pace, guys, given the agenda. Thank you, Frank. I think the challenges of our cities is absolutely enormous, and but as Glenn said, it's a very city-focused challenge. moving on then to the integrated performance report. Jane, what key points would you like to highlight first of all?
Thanks. Just a few things to start off, and just to add as well to that comment about staff home working. We've done a lot of engagement with staff, and there's no doubt it is very popular. And what most of our staff who've been working at home are looking for in the future seems to be a blended approach for, so sometime in the office and sometime at home. And obviously there's a real financial positive end to that for us as well, in terms of the amount of estate that we have to have over to office space. So I'm sure it will continue to be a feature. So I really look at the performance report then. So the last month has been a pretty intense time of planning for recovery and starting the implementation of that. John's got a spot on the agenda later on to take you through some of the detail of that. But I guess overall it's a reasonably positive picture at the moment of we are delivering against the plans that we set out. We're doing the activity that we said we would do at this stage. And we are, but the big test is really coming. So during September, it's a real step change in bringing back much more activity and doing that safely. So I think we'll be able to test that out over the next few weeks, and our next board, hopefully, the picture will be just as positive. A few other positive notes that I wanted to pick out as well. So pathology, and our pathology team has definitely been a really positive story right through the pandemic, and has meant that we've been able to manage pathways as safely and as well as we have. And their latest innovation, which we've just funded, is that from a single sample, they will be able to test patients who are symptomatic for both flu and COVID on the same sample. And that's really going to help with flow right through the organisation over winter. And so that will be coming in quite soon. The other positive thing really is that, and Glenn's really mentioned it, that building on the positive things from COVID, and how do we keep that going into the future. So the transition board and the clinical practitioner forum have really started to work, and a couple of projects that they're working on, and again we have already touched on these, is so jointly managing waiting lists between primary and secondary care is one of the projects that started to really motor. So it's not just managing risk for patients who've been waiting a long time, but how do we manage the capacity? How do we make our pathways so effective and efficient that we use the limited capacity that we've got? And that's really started to work. And the other area we're concentrating on is around the discharge pathways. And again, there's been some absolutely fantastic work on this. And I'm reasonably confident as we bring back those continuing healthcare panels that we will find ourselves in a better place in the future because of the work that we've done. So again, all of that is positive and building on what we've done. And the last thing I wanted to talk about, I think, was the workforce metrics, again, going back to the people plan. Again, all of those workforce metrics, with the exception of appraisals, which we've got a bit more work to do on, are still looking really positive. And we have signed up to the national regular pulse survey, which I think is going to be every month from now on. And we've got the first results back from that. And again, it's a way of regularly checking with staff how we're doing. And so far, the results are pretty encouraging, and we look like we're above the national averages. And again, Jeffrey can talk to that. So those are the things I wanted to start off with.
Thank you very much, Jane, and thank you for joining us from your holiday. Questions and perspectives to Jane, or do colleagues want to dive into the detail?
Can I, Chair?
Andrew?
Just a question on the performance data. We may have touched on it before, apologies if we have, is the standards for cleaning, which consistently show a reducing level of performance, although it's not clear whether there's data available or not. Just because it was raised earlier in the workshop as well, I was just wondering where we are on that.
I'm not sure of the detail, but Lucy might have more information, or we can come back to you later.
Lucy, do you have more detail? Would you care to come back under matters arising?
I'd like to come back under matters arriving in detail, but I know at Infection Prevention Committee last month we received our quarterly report for cleanliness, and actually the scores are improving. So we might just need to check the data and just look at that offline and come back to you, Andrew.
Thank you, Lucy. Thank you, Andrew. Colleagues, happy to move on then to the quality report? Thank you, Jane. Lucy, do you want to cover off the quality highlights from the report? Obviously, we've read the report.
Yeah, just a few points from me. So I'm pleased to say that my Associate Director of Nursing has established a patient safety group. And the patient safety group focus initially will be on the top 3 harms that we experience, that our patients experience, which is pressure ulcers, falls, and medication errors. Now, we're not an outlier for pressure ulcers, we're not an outlier for falls. As we've heard here previously, we have got concerns about moisture-associated skin damage, and we don't think our visibility at board level on and quality committee level around medication errors is where it needs to be. So there's a deep dive into falls and pressure ulcers at quality committee next month, and then thereafter we'll bring a patient safety report on a quarterly basis. I'm thrilled that we've been able to advertise for 2 non-medical clinical fellow posts, one relating to dementia, to champion that dementia. So non-medical clinical fellows will work half-time in practice and then half-time in education, educating our workforce. So it's really great that we've got one for dementia to champion that agenda, and then the other for nutrition. And if we recall our CQC inspection last November, the CQC highlighted that our nutrition steering group hadn't met for some time. We've now re-established that. That's been chaired by one of our consultants, and certainly the clinical fellow will be part of that, particularly focusing on those high-risk patients who are artificially fed, and the training and education around that. Although not mentioned in the report, but just under complaints, one of the features of our complaints is around discharge planning. And certainly at the board workshop this morning, when I presented on the inpatient survey, discharge was a feature in our inpatient survey too. And I'm pleased that Health Watch want to work with us closely this year, and they're going to work with us focusing on discharge as part of our quality improvements around that. You'll note in the report I've just put the Clostridium difficile data wasn't accurate, but my narrative reflects the accurate position. I was a little concerned around the number of Clostridium cases that we're seeing at this point in the year against a trajectory of 36. And what we're seeing is a rising number of community onset Clostridium cases rather than hospital onset. So I've just commissioned a piece of work that we're going to do across the system to look at Clostridium cases that commence in the community. And then we had a debate at Quality Committee just around some of the Quality Committee performance indicators that go through that committee and then on to board, just to see if there are any changes that we wanted to make. We had a long debate about whether there should be any COVID-related performance indicators. And our conclusion at the end of that was that there wasn't anything routine or specific that should come through the quality aspects in relation to COVID-19, but clearly we would report on any hospital-acquired infections or outbreaks should we have them. We acknowledge that the safety thermometer has been stood down nationally and therefore will be removed from the performance indicators, but acknowledge that those indicators are picked up under other pieces of work, so the pressure ulcer quarterly report, falls, and the other relates to catheter-related UTIs, which is covered in our gram-negative bacteremia work. And then the final thing we discussed was that there's just a small number of indicators that come through to board in relation to maternity quality outcomes. Yet there's a much larger dashboard that looks at all sorts of quality outcomes within obstetrics and maternity. And so in future reports, we'll bring some broader indicators for maternity through to board rather than just the 3 or 4 you ordinarily see. And then finally, the deep dive at Quality Committee this month was around our theatre safety culture, which is contained at the latter part of the report, and just a few highlights from me. So board will recall that following the CQC inspection, we received a section 29A warning notice that in particular focused on theatre safety. And what the deep dive does is describe a range of activities that the surgical division have undertaken in order to address theatre safety and the matters that were featured in the section 29 notice. So for me, some really good work around the WHO safety checklist. A multidisciplinary team came together to review and revise the checklist. And that had to come back to clinical audit and effectiveness on a couple of occasions, actually, because it needed further revision. But that's now been approved. And what the auditing of that is doing is demonstrating proper application of the process now. So we are seeing theatre safety checklist huddles being paused to ensure that there's full engagement by all parties, which is therefore achieving full compliance with the WHO checklist. We've seen significant improvements in hand hygiene and bare below the elbow scores, and they are peer audits. So they're audits undertaken by other individuals visiting the departments and covertly observing hand hygiene and bare below the elbow practices. But it was also necessary to make changes to the environment to make it clear where people needed to be bare below the elbow and observing hand hygiene. We put in place appropriate escalation processes so if people weren't behaving or didn't respond to a challenge, that could be escalated and dealt with appropriately. The surgical team have put in a revised management structure within theatres. What that's enabled is clarity on roles and responsibilities, strengthened leadership, and a specific focus on governance. And then generally in relation to improving theatre safety, the daily briefings or the daily huddles focus on the safety of our patients in theatres. We've got an ongoing training programme that looks at human factors. We've undertaken a cultural survey and are addressing good practice in any areas of less favourable behaviours. And we've got a plan for a masterclass that's called Let's Remove It, which is about civility in theatres and team working, which is scheduled for the latter part of this year.
That's very comprehensive and very assuring update on the deep dive on the surgical areas. Lucy, thank you. Questions and perspectives to Lucy? Please come off mute if you have. I would just say to members of the public that on Lucy's comment about the research fellow on dementia, about 18 months ago, the board were trained to become dementia friendly, which was very valuable. And I'd encourage members of the public who haven't done the Alzheimer's Society training course, which I'm sure is available online now, to become dementia friendly. It's a very worthwhile thing to be able to, or to do, to be able to understand and appreciate more people and their families who are living with dementia. Colleagues, happy to move on to the activity report from John. Super. John, can you just pull out the highlights, please?
Yeah, thank you, Chair. I'll take the report as read. I won't cover the planned care elements because we talk about them in a little bit more detail in the presentation in a few items' time. In terms of urgent care, later on in my slide, my pages, the pressure from emergency tenancies is starting to return with attendances nearly where they were pre-COVID and conveyances just about where they are. We are getting particularly busy at the weekends, which I think it says in the commentary there. And that is creating some pressure for us. Performance is still higher than it was before we went to COVID, but not quite where it needs to be. Some of this is driven by a split ED solution to manage both blue and yellow work streams. But that's changing on Monday, and we'll see a more streamlined flow through ED, so hopefully performance will continue to improve. It has picked up this month over the previous month. Same-day emergency care is really a huge focus for us at the moment, and as you can see here, it improved in July and has improved subsequent to that still. And there's a large piece of work going on tied in with the capital works we've got to improve the same-day emergency care area. The Think 1-1 programme we're contributing to and going to run. And so working across primary care, some really innovative approaches to deliver the same-day emergency care. So that is a focus now, and it's a focus for the rest of the winter. As you can see there as well, bed occupancy is starting to climb back up, and actually we are struggling with capacity at the moment. So avoiding admissions and maintaining good levels of discharge are really important to us going forward. But there is some risk over the next few months if we can't maintain flow. That's all I wanted to talk about really for this section. Thank you, Chair.
Thank you, John. And again, we across the foundation group talk about the Wye Valley Way and the innovations that's led to, and John, you've led that, and it's really having an impact, not just in Wye Valley, but also across other parts of the NHS. So well done you. Questions and perspectives to John, please come off mute if you have. We'll be glad when the hutted wards aren't hutted wards anymore, but are properly built wards for us to be able to take some of the pressure off John on the bed. So it's going to be a tricky few months, so you have our full support. You're doing a great job. Colleagues, happy to move on to workforce? Jeff, workforce.
Thanks, Russell. Well, in terms of the workforce report that was reported by Jane, we're making good progress on most of the KPIs. We're working with managers on performance appraisals, and we're picking out internally. So the expectation will be that in September, October, those outstanding appraisals will be completed. In this report, I've included a new table with just some HR OD highlights. So hopefully you find that useful. And my intention will be to update the table on a monthly basis with just some key developments within my function. In terms of the National Poll Survey, Jade mentioned the National People Poll Survey. So the report includes a summary of the feedback we received from our staff, and it's very positive in terms of the leadership and also the support that we've provided over the last few months. So it's very reassuring to see that our staff feel supported and well led, certainly over the previous few months with the COVID crisis. Just one other thing I wanted to mention, the government have launched a new scheme called Kickstart for trying to retain young people within employment arenas. So we have expressed an interest in that because we are very keen to do everything we can to support and retain young people in employment. So those are the key things I wanted to cover. Happy to take any questions.
That's great, Jeff. Thank you. Questions and perspectives to Jeff? Really great to have you on board, Jeff. Again, the way the session was led this morning on leadership styles gives me a lot of confidence about the impact you're going to have. I'd also just like to say to particularly the younger people in Herefordshire, considering their careers in these uncertain times, the NHS is a great place to work. And we as an employer are interested in the content of your character. If you've had challenges at the start of your life, which might be educational challenges or other challenges, I just want to say on behalf of the board and therefore the organisation, we're interested in the content of your character. Come and apply. If you've got the makings of a great NHS colleague, you know, we want to hear from you. So please do come forward. We want to be one of the best, if not the best employer in Herefordshire. So please do come forward. It's a great time to join the NHS. The colleagues are great and the pension's fantastic. Even though it's changed a bit, it's still a fantastic pension. Colleagues, happy to move on? So Howard, tell us about the money.
Well, I'm pleased to say it's been a fairly unexciting month financially. So really I can take the report as read. Just a couple of points I wanted to make. We returned a break-even position in July again. This is in line with the sort of national expectation. We've now had a retrospective top-up of 1.3 million, so that has helped us get to the break-even position. But I think the key thing I did just want to highlight was it's something that Glenn alluded to before. The current arrangements by which we've been getting a block contract settlement and then some retrospective top-up. This arrangement comes to an end at the end of September. We have been waiting for over a month now for our allocation for the period October to March. We still haven't got it. Our initial assumptions suggest that we could well be back in a deficit position from October onwards, but obviously I await to receive the allocation and then we'll work that through. I'm expecting to be able to report to the board on that position next month. So otherwise I'll take the report as read. Happy to answer any questions about the financial position.
Thank you very much, Howard. Questions and perspectives to Howard? Please come off mute if you have. Andrew, just as chair of audit committee, I know you'll be ensuring that the sort of audit trail, which we talked about a few months ago on COVID-related spends, is to your satisfaction. So maybe next month, if you could just give us, or after the next audit committee, give us a bit of an update on that, that would be fantastic.
Yeah, okay, that'll be fine.
Okay, super. Colleagues, happy to move on? Okie dokie. One of the great things that we are doing at Wye Valley, for the knowledge of members of the public, is our digital program work. And so, Howard, can you please provide us with the update report or the highlights?
Yeah, thank you, Chair. Again, I was going to just take the report as read, because we've tried to convey quite a lot of information in the report. Hopefully people will take from it that we continue to make good progress. We've referred to a number of the ongoing developments that we've made over the last couple of months, and these initiatives continue to be rolled out. The one perhaps slightly negative part of the report is the fact that as a result primarily of COVID, but also due to other sort of supply-related issues, the actual completion of the EPR programme is looking to slip beyond where we had originally anticipated. We're working through the details of that at the moment, and obviously we'll come back to the board as soon as we have got confirmation of that. But one of the positive things which has been commented on in a recent NHS Digital review, because as colleagues will remember, NHS Digital are taking a very close interest in this, because after all, £5 million of the funding has come from that source. They have actually commended the changes which we've implemented over the last 8 months, and including the combined digital implementation plan, which we're still working on, but is making good progress. That actually brings together a number of the different streams of work, including most specifically EPR and EPMA, and the fact that we are now viewing them as one programme with a number of streams rather than a number of separate individual projects has actually received very, very positive response from NHS Digital. So again, I'm happy to take any questions on any aspect of the paper.
Thank you very much. Howard, any questions or perspectives on the digital update report? Frank?
Yeah, the cost of overrun, what's the order of magnitude? And what does the contract say about things like that?
Right. So firstly, Frank, we are in the process of working that out, because I can't say categorically how long it will overrun. I genuinely was bringing it to the board's attention, but I am hoping to be able to provide more information next month. It will be the cost of the overrun is unlikely to be in relation to the contract with the supplier, and more about keeping our implementation team together. It will be a figure of a six-figure sum, but I will provide board with information on that as soon as possible.
Okay, that would be great, Tad. If we can put that in the minute points, Val, and then we can monitor it. Thank you, Frank. Any other questions to Howard on the digital update?
Chris, let's go on.
Sorry.
Yeah. No, I suppose it's a bit in relation to that. Previous 6 months more ago, we were concerned about the health of the supplier, and I just wondered what news on that, and are we confident that they will see us through now?
That's an interesting question, Chris, and it was one I was asked by NHS Digital only this week as part of their recent review. Glenn and I met with the owner and interim CEO of IMS Maxims earlier in the year, and as the funding, the major sort of benefactor to the company, he gave us his absolute assurance of his continued involvement and support of the company. NHS Digital haven't actually raised any further questions with me recently about the company. So at the moment, we are confident that the company is continuing as it has previously over the last few years.
Okay, thank you, Howard. Colleagues, happy to move on?
Yeah, I mean, just if I may, Russell, just on that point, yes, I mean, I was certainly assured by the focus of the chief executive. They are a small company, though, so I think that's something, you know, in this space, they will always be a risk from that perspective, but they're certainly committed to this project.
Okay, great. Thank you, Glenn. Okie dokie. So, Alan, the update from the Trust Stakeholder Council, please.
Thanks, Chair. I'll take the report as read. We've had 3 meetings since I last did a report to the board, and they're set out in the paper. We missed 1 meeting due to COVID, and we've moved into an online meeting via Teams now. One of the things we're turning our attention to, as we've got greater focus on working in an integrated way across Herefordshire, we're looking at how that might change the stakeholder group to consider issues beyond just Wye Valley and look at the wider issues affecting Herefordshire as a place.
Fantastic. And so you're pleased with the way it's going, Alan?
Yeah, very much so. Yeah, I think one of the things that invariably you come across is that you want to have conversations that affect primary care, mental health, and obviously those stakeholders aren't around the table. It's very much a Wye Valley group. So I think the idea is if we broaden that out to reflect the way we're very much working in Herefordshire now, I think that will make for a much richer discussion.
Great, super. Questions and perspectives, Glenn?
Yeah, I just wanted to commend Alan and Frank for getting that group up and running. If you remember, it stemmed from our original proposals when we created the group arrangements, that we were trying to create a situation where there was more public accountability like the Foundation Trust model. So I think it's great to have that forum, and I think it will naturally move into more of a place-based relationship as we move more into the leader of a place-based model.
Thank you, Glenn. And Frank, anything you'd like to add?
Yeah, I find it a bit frustrating. It's powerful and it's going quite well, but I really feel it ought to be a lot broader.
You mean in terms of a church of people?
Beg pardon?
Sorry, you meant when you said broader, do you mean a broader church of constituencies?
Yeah, I do. I just don't feel that we're yet reaching out as far as we could, and how much more powerful it could be. And I think we could give some thought to how we make that reach broader.
Okay, well, Alan, if you can take that away, and maybe Frank, you know, if you haven't done already, just drop a note to Alan in terms of your suggestions as to how we could do that and how we can broaden the Kirk of involvement. That would be good.
Yeah, I mean, to be fair to Alan, we have talked about it. We both agree on the overall theme. I just feel that we as a big organisation should embrace that more and watch for opportunities to broaden it.
Yeah, okie dokie. And any other comments on the Stakeholder Council? Okie dokie, super, thank you. So we'll therefore move on to our COVID update. The 11-page report here. John, do you just want to pull out the key points? Obviously, the board have been able to read it.
Sorry about that, the mute button moved. Yes, next slide, please, Eric. So I'll just run through quite quickly, if I may. So Plan B, which is our current working plan, is also known as our best offer plan. This is what we can best offer with the resources available to us currently. Just in terms of oversight of that, really governance of that, the divisions review that on a daily, weekly basis. I hold a Teams meeting once a fortnight where we go through a specialty level. We open that up. That's quite broad. About 35 people dial into that. We've got colleagues from CCG, SDP, and NHSIE as well dialing into that. So it's a very open book. And obviously we'll review that monthly to our finance and performance executive as well. We submitted our first cut plan in response to the phase 3 restoration letter on Tuesday. as an SDP. Our contribution was aggregated into others within the SDP, and that goes again on the 21st, and that's gone out regionally, and then we'll go nationally. So there's quite a bit of oversight and an awful lot of data that's flown out from the trust over the last 10 days, and thanks to the information team for a huge effort in terms of completing that on time. Demand, really, you need to talk about demand because it's 2 weeks are largely back to where they were when we would expect them to be at this time of year. There is some variation with this specialty worth noting. Urgent's approaching that, looks like it's following a similar sort of pattern as well. Routine, however, though, remains significantly below, and I think the next slide probably shows the fact that it hasn't changed at all over the last 8 weeks. So we're down 10,000 appointments so far year to date. The cumulative, so it's not a month, that's a cumulative effect of referrals. So a concern about what's happened to that demand and when we might like to see that demand again. But obviously, all of our plans depend on referrals behaving in the way that we expect, which is growth back to near 100% later in this calendar year. So next slide, please, Erica. So that's just the referral variation. You can see I just put that in because I just thought it was noteworthy. That red block at the bottom really is just showing that actually it's quite flat over the last 8 weeks, and actually there's quite a lot of variation in it, more so proportionally than there is normally. So still things settling back down to normal, and hard to see what the future over the next 8-12 weeks lies, but obviously we're planning for that. Next slide. So activity against plan. So new outpatients there, you can see the top little chart on the right hand side. Largely, despite the social distancing and COVID precautions in place, which do significantly impact on productivity and capacity within our outpatient areas, we are on plan, but there's quite an uplift in our plan this week and next week. So next month will be very telling in terms of are we able to track that increase in our plan. I believe we are. I'm confident that we can, but obviously we yet to do that. And then follow-ups the same. The uplift's not as great. There's a high proportion of virtual appointments held within follow-ups, so the uplift was required wasn't as great. We have secured some monies, and the money that Glenn spoke about earlier on in this meeting, and we're looking at how we might create some greater virtual clinic spaces to free up space for face-to-face appointments, and also some sub-wait areas so we can maintain social distancing and get a better throughput through the department. So next slide, please. Remote clinic activity, they're the national targets, apparently. So 60% for follow-ups and I think 25% for news. We were obviously early on in the pandemic, last week, one of the financial year, we're exceeding the targets. It's coming down now. I think it's hard to know what's achievable and what normal will be. We're about 40% currently. Medicine, however, perhaps have an easier job of seeing people remotely than surgical specialties, are still over 70% as a division in terms of virtual appointments, which is fantastic. We do need them to keep that up, and I do think it offers some real advantages for our patients and our staff. Next slide. Inpatient admissions, non-elective, talked about just very briefly earlier. You can see they're climbing up to near normal levels, and total electives there, we're ahead of our plan. We've exceeded our plan so far, but obviously that very sharp green line is actually the 7th of September when we open up the remaining theatre lists and see more throughput. So that's again a challenge, but we are confident. There's a very comprehensive piece of work going on to make sure we're ready for that. We've got the right beds and the right theatre spaces, etc. So we're confident we can do that. There is part of that work is to continue use of the private sector, which obviously is secured to later this financial year, but our plan does assume we'll continue to be able to access that in the volumes that we expect to. So it's just a thing for us to continue to work with our colleagues from the Nuffield to make sure that happens. Next slide, please. This is a fascinating slide, I think. So the waiting list, so that's the size of the waiting list. So actually the waiting list is almost identical to the size it was when we started. It did shrink slightly as referrals dropped and activity carried on, and now referrals have started to grow a little bit. It's grown a little bit, but actually it's largely where it started. So the number of people waiting for our services is roughly the same as it was. The time that they're waiting for our services has significantly changed. So that green line is under 18 weeks, the amber is on 18 to 25 weeks, the red's 26 to 51 weeks, and black over 52 weeks. And those red and black and amber lines red and black will continue to grow for a little while. We are, by year end, and I probably should have put a year end plan, you will see that the numbers of long waiters decrease, the proportion of under 18, because will increase by March. So I'll make sure next time I put that in so you can see it. You did see it previously last month, but it's probably helpful to see it in an ongoing way. But that's it. Really, it's the shape of our waiting list has changed rather than the volume of it. But clearly, for individuals waiting, their experience has changed. Endoscopy is a real concern. So total endoscopy waiters. This includes planned and surveillance. You may see some other figures from elsewhere that will just be RTT patients, but this is the patients that we need to see. So it's why we look at it this way. There is a significant COVID impact on productivity within endoscopy units. So it has slowed units down overall. And we are continuing to work with clinical operational teams to try and find ways to put more capacity on and be more productive within that capacity. So you can see the red lines last year in terms of volumes of patients we were seeing, and the blue bars are what we're doing this year. So significantly down. It's about 40% of previous growth, and the impact of that so far, because of reduced referrals, hasn't been very sharp, but still a large number of additional patients waiting. But by year end, we'll see growth at somewhere around about 1,500. So we need to find a solution to additional volumes of activity for endoscopy, which we're working on, and there's some more starting next week. So we'll recut this plan as those plans come into place. Next slide, please. Imaging, it's a more positive story. CT and ultrasound are actually doing more work than they were this time last year, and they're getting less referrals, so they're actually reducing their waiting times. With the one issue we've got just in terms of the kit that's available currently, because of the replacing both of our CTs with new CTs, we're unable to deliver CTC currently. There are clinical alternatives, but we do need to find an alternative, so we're working to resolve that. And MRI is a little bit behind where it was last year's activity. It was 88%, but actually that's still greater than the number of current referrals, so they're also reducing their volume of patients waiting. So good news. So in summary, demand remains below previous year. The divisions are currently delivering their plans. So Plan B will continue to develop as we find new ways to achieve what we need to. The step changes in volumes of outpatient and patient activity planned for next week is a challenge, but we will rise to that challenge. We will meet that challenge. We do need to resolve the endoscopy capacity demand gap, and we do need to make sure we maintain access to the event sector for both inpatient and outpatient activity. That was it. Thank you.
Thank you, John. So obviously lots of challenges, lots of agility being applied to the challenges as they develop, but you're feeling pretty assured that we're making solid progress, John.
Yes.
Thank you. Questions and perspectives, Glenn?
So good work on that, John. Just a couple of quick questions. Firstly, on the routine referrals, are there any particular specialties that stand out in that, or is it across the board? And the second question is, in our regional return, we'd flagged the cath lab as an access issue around recovery. Is that resolved?
I think the routine referrals, it's a bit of a mixed bag in terms of volumes. I don't think there's any particular, it's not being driven by any one specialty, but they're all down by varying degrees, if I'm honest. Some will continue. I mean, hematology, routine hematology is down quite a bit, but all their urgent works hasn't been touched at all through the pandemic. So there's lots of variation. Cath labs, which we're doing some work on some diagnostic modelling tools to try and understand that. They've done remarkably well to maintain sort of quite high levels of activity through the cath lab in recent weeks, but there still is an impact on their productivity. I think they're down about 20%, whereas I think the regional assumption was about 40% reduction in cath lab activity. So they're doing quite well, but it is an issue. We've just finished the endoscopy piece, so we're moving on to the cath lab piece now to understand that better.
Okay, thank you, Glenn. Any other questions or perspectives?
Hi, it's Nicola here. Hiya. It was around the remote clinic activity and the targets that have been set. John, are those ones we've set locally, or are these ones that we're being centrally guided to adopt?
I think no, they're not certainly not local targets. I don't know how you would set a target, because I don't know how many you can.
Yes.
If I'm honest.
Yeah, that's what I wondered.
They're national.
Okay,
well,
thank you.
And I think there are some things. I mean, the one I don't like is the patient-initiated follow-ups I feel instinctively nervous for our older patients on that and their families. So I think that's something for us to definitely keep an eye on.
Yeah,
the world
I'd
of
be really
unintended
interested. Yeah,
the world of
Yes, sorry.
unintended consequences on that one could be significant. So, John, just keep an eye on that and just keep us briefed.
I mean, I think PIFU does have some value, particularly some long-term condition management in terms of making sure we intervene with patients when they need it, not at a random date in the future. But I think that all needs to be supported by a proper support structure with patient portals and etc. We're working on that to do a piece of work.
Yeah, but I think for some of our older patients, you know, understandably, I get confused with passwords and everything else. And hopefully I'm a reasonably youthful 60-year-old. But for older patients, I do worry with that notion that we need to make sure our MDTs and teams are on the sort of customized approach to appreciating what individual patients need. Any other comments before we move on?
Chair, just
Chris, first of all, Christabel.
Sorry, thank you, Chair. I just wondered, not the routine, the electives, but the diagnostic patients who were cancelled at the time of the COVID started. How are we talking to them and making sure they're back on track?
Well, certainly with the Welsh, we did an exercise for all the patients from Powys. There was only a handful of patients actually cancelled. Most of them weren't. It was a very short-lived action that we redressed. So certainly we've gone through an exercise and reviewed all the referrals for diagnostics from Powys, and we're going to have to undertake the same for Hereford as well.
Okay, thank you. And Andrew, did you want to?
Yeah, just a follow-up to Glenn's question really about specialties which are particularly low on the routine demand. Is it possible to look at what conditions are not coming in? Because there must be certain conditions where people are making the judgment that it's less risk to come to the hospital than it is to stay with a sore knee or whatever.
Yeah. I think, John, if you can maybe give us more granularity next time, that would be great. But I think the principle, Andrew, which you're sort of alluding to is, for members of the public, the NHS is open. We're here to help you with your healthcare needs. If you've got a genuine healthcare problem, please contact your GP or 111. We don't want you holding back. The healthcare system's here to help you. So can you provide more granularity on some of those service level issues, John, at the next board?
Yes, I will do, yeah.
That'd be great. Anything else, colleagues? Okie dokie. So moving on, I can only see 9 of you, just so you're aware. So the other 9, I have to switch screens. So if you can just not put your hand up, because you might not be on one of the 9 people that I can see on my screen. So we've got then the Quality Committee for the 30th of July. Chris, anything you'd like to add to this?
Thank you, Chair. Just to bring your attention to the results of the National Cancer Survey. I've been looking at this year on year since I started, 2015 or 14 even, and this is the best year by far, and it's a credit to staff. And interestingly, it will be useful to look at how those things have improved, and in relation to our inpatient survey that Lucy was talking about earlier. Also to say that we're noticing a small increase in SHME and HSMR. Medical director feels at the moment, with appropriate scrutiny, we should just hold fire. It may be as a result of our reduced denominator of admissions into the hospital, but we're just holding firm on that, but keeping a very close eye. I wanted the board to be aware of that. And the final point, Chair, if I may, relates to the meeting last week on the at the end of August. NHSI asked the Trust to bring to the board's attention a risk assessment undertaken to ensure that the care of our neonates and their parents was being safeguarded in terms of social distancing when parents particularly visited the unit. A risk assessment was done, presented to the COVID operational group, and agreed, which allowed the use of an underutilised room to allow the cots to be spaced out. We've all been assured at Quality Committee that that's been appropriate risk assessment and appropriate things have been put in place to manage that. But HSI wanted us to bring that to board attention as well. Thank you, Chair.
Thank you, Chris. Any questions to Chris? I think in other bits of the NHS, Chris, the issues on shimmy and HSMR are trending as ours are, which does appear to be a denominator issue, but will be clear in the next few months. And then, Chris, on the 25th of June Quality Committee, anything you wanted to add?
No, Chair, I've already brought the summary to your attention. Thank you.
Okay, any questions from the 25th of June Quality Committee report minutes? Okie dokie, any other business, team? Please come off mute if you have. And I understand, Erica, we don't have any questions from members of the public. So Chris, if you're watching this YouTube video, we are missing your questions. So we look forward to seeing you digitally in the future. Our next meeting is on the 1st of October, same time. Thank you very much. Team, Val or Erica, if you can turn off the live on